let's get into lower motor neuron circuits and motor control. So we're gonna, even if we don't get to that point yet today, I still want to get to the slide where we're going to go through all the different reflexes so we can at least do the reflexes on each other. So that'd be fun. So these are the topics that we're going to be covering with movement. We're going to talk about subunits of the motor system. So lower motor neurons. We're going to talk about upper motor neurons, cerebellum, and basal ganglia. So we're going to be revisiting a lot of stuff that we already covered way back in the beginning of the semester. So some of the different tracts that we discussed earlier on. We're going to talk about how you have organization of these different types of motor neurons. So it's somatotropic organization. We're going to talk about alpha versus gamma motor neurons. We're going to talk about motor units. We're going to discuss how twitch takes place. So twitch, temporal summation, unfused and fused tetanus, reflexes. We're going to talk about spindles, the Golgi tendon organ, and we're going to talk about ALS at the very end, because ALS is a upper and lower motor neuron disease. And so it basically kind of summarizes everything that we talk about when it comes to our motor system. So here are the different distinctive subsystems. You have your lower motor neurons, upper motor neurons, cerebellum, and basal ganglia. So upper motor neurons is going to be brain, then spinal cord, then down to the lower motor neurons, which go off to the extremities. And then you have your cerebellum, which is basically going to come in to help smooth out movements, to allow for balance, to allow for posture. And then you have the basal ganglia, which we're going to get into very heavily next week, which involves the controlling of both initiating voluntary movement and controlling involuntary movement. So you can dampen down unnecessary type of movements. So all these systems are all going to come into play together. Plus you have sensory inputs. So you have afferents coming in to basically signal to your cells what type of reaction you must engage in, right? Especially when it comes to reflexes, right? So we're going to talk about cross-extension reflex, the withdrawal reflex, right? When you're trying to avoid painful stimulus, danger, things that might damage, tissues. So all of that comes into play together. Now, the lower motor neurons are going to be innervating muscle fibers within a single muscle. All the motor neurons innervating a single muscle. This is called the motor neuron pool. Whoops. Sorry about that. What's going on here? Cool. So motor neuron pool. Here's some information from your guys' textbook that you might find valuable, but I'm not going to go into full detail about here. Just talking about the distribution of motor neurons in the spinal cord. We're going to talk about that in a second anyways, so that's just FYI information. So the way the spinal cord is going to be laid out, where you have distribution of motor neurons, where you have medial ventral horn, so that's going to be closer to the middle. That's going to be innervating the axial and medial type muscles, whereas the lateral ventral horn is going to be innervating distal limbs. So the more lateral you go within the ventral horn, the further away you're going to see innervation. So like the tips of your fingers, right? The distal portion of your extremities, that's going to be more lateral. More medial to that, there's going to be innervating muscles in the trunk. For example, your core muscles, right? So axial muscles. And so this diagram I really like because it shows exactly what it looks like. Hands are going to be distally, more laterally in the ventral horn, whereas more proximal muscles are going to be more medial within the spinal cord. So that's some basic organization. You're also going to have different circuits in play. So you have the medial ventral horn. That's going to be more long distance communication, whereas the lateral ventral horn is going to be more short distance. The medial ventral horn, you're going to see involved in more posture as well as locomotion type of movements, versus the lateral ventral horn is going to be more fine control, more fine control of the distal extremities, right? So your fingers and your hands. Yes.
So the lateral ventral horn is distal limb muscles, but it's
shorter distances, but yeah, distal. So if you follow
the distal extremities.
Yeah, so for example, here's a lateral ventral horn, so it's going to be a little bit shorter in terms of distance. Whereas medially, you're going to see those neurons are going to be traveling longer. Yeah, they travel in a longer distance, but it's going to be innervating the more proximal type of muscles. Travels longer, but it's more proximal versus the lateral distal appendages. The type of motor neuron units that you're going to see are alpha motor neuron units as well as gamma motor neuron units. Alpha is going to be for voluntary muscle control. So it's going to be innervating striated muscles. The gamma motor neurons are going to be more sensory receptors. Okay? So you're going to find gamma innervation and alpha innervation in muscle, in skeletal muscle. But alpha is motor, gamma is sensory. So we're going to talk about that in a little bit, where those neurons go. Now, this is not super high yield, but these motor neurons are going to be varied in their sizes. So you have some that are going to be smaller versus some that are bigger. You also have speed that's going to vary amongst these different motor neurons. You're going to have slow motor neurons. Those are going to be more for posture. Fast, fatigable motor neurons are going to be for things like jumping, right? A lot of force in a short period of time. It's fast, so you can do some more explosive type movements, but they're going to fatigue much more rapidly. You have fast fatigue resistant motor neurons. Those are going to be generating force that's greater than slow motor neurons, but they're not going to fatigue as quick. Right? They're not going to fatigue as quickly as the fast fatigable motor neurons. And you get changes in your motor units as you do things like exercise, right? The more you exercise, the more type of changes you're going to see within your skeletal muscle. You're also going to see the motor neurons innervations are going to be a little bit altered. You're going to see some plasticity in motor neuron innervations. You can also see experiments using electrical stimulation. So if you stimulate certain regions, you might start seeing the muscle types changing. So in this example, after 50 some days of stimulation with electrical signals, you see your fast fatigables turning into slow type muscles. So with more stimulation, you're seeing increases in instantaneous discharge rate, but you see decreases in the intervals to allow for contraction. So long story short, you're going to see plasticity within motor, the muscles, as well as the motor neurons as they are being stimulated. Now, with increased motor unit size, you're going to see changes within the motor units. So you're going to see more cell bodies, you're going to see more dendrites, you're going to see excitatory postsynaptic potentials, you're going to see the diameters are going to change, the number of axon branches, all these things are going to change with stimulation, with exercise. So literally electrical stimulation can induce these types of plastic changes, which is super interesting. So here's more details about these types of studies using electrical stimulation. I'm not going to go into too much of this with you guys. There's other things I want to cover instead. So here's some more plasticity type examples. This is just FYI, extra information just for you guys. Now, here's the size principle. So this is going to happen with more physically demanding tasks. So with when you're standing, so the percentage of maximum force, when you're standing, you're not going to really need a lot of muscles coming into play. You can just use your slow type motor muscles, right? That's just literally for allowing you to maintain your posture, maintaining your gait, for example. As you start getting more into movements like walking and running, you're going to start using more of your fast fatigue resistant type muscles. But then as you start increasing the demand for more like explosive type muscle movements, that's when you start using your fast fatigable muscles. So in other words, you're going to use different muscle groups depending on the actual task at hand. So pretty basic stuff. So this goes into more detail about all of that. Now, in terms of stimulation of the muscles, this is going to go back to when you guys took AMP. You guys talked about this in part 1 of AMP, but we're going to revisit that right now. So here's you have temporal summation, which eventually leads to unfused tetanus, which eventually leads to fused tetanus. So with a single muscle twitch, you're literally just having one signal, bam, then you get a muscle twitch. Another signal, bam, and you get a muscle twitch. Now, if you start increasing the frequency of signal, right, you start having faster signals, then you're going to start seeing a thing called temporal summation. This is also referred to as trepe, right, where it's kind of like a step-like increase in the amount of muscle contraction that you get. And that's because you have those stimulations occurring at a more frequent pace. As you start increasing the electrical signals, now you start seeing more of a tetanus type scenario, right? So there's going to be unfused tetanus where you're still getting some fasciculation, some twitching of the muscles until you eventually get to fused tetanus. And that's where you're having constant electrical stimulation of the muscle. And then fused tetanus meaning that you're not getting any twitches, right? So individual twitching of muscles is not going to happen anymore at that point. The muscle just basically all just contract and they stay contracted. So that would be fused tetanus. Are we good on that concept? So to reiterate, you get single muscle twitch, right? So you have one stimulation, muscle twitch, another stimulation, muscle twitch. Once you get into temporal summation, which is also referred to as treppe, right? Treppe, I think, is a German word for stairs. And so with treppe, you start getting more of like a additive effect. You get more and more contractions. And then fused tetanus, you're going to get twitches versus unfused tetanus, no more twitches whatsoever. All right. With increasing amount of force, you're going to get more, a larger recruitment of muscles, right? More motor units are going to start being recruited. So the more stimulation, the more need you have for muscle activation, you're going to see more motor units coming into play. Moving on. Now, let's switch gears and discuss reflexes. There's a lot that goes into reflexes, but we'll do some broad categorizations here. So there are some reflexes that you are born with. So moral reflex is an example. Grasping reflex is an example. I'll show you some videos of all those different types of reflexes in a little bit. So those are innate reflexes, you're born with them, but then there's reflexes that you acquire. So for example, if you were like studying martial arts or something like that, right? That would be, you would have acquired reflexes that you literally learned, right? Through repetition, and you became an expert at, whatever craft that you're performing. Martial arts, you can even see this in sports, music, performance, things like that. There's also different types of responses. So you have somatic reflexes, which are going to be seen in, like, for example, if you like stimulate your muscles to do a reflex, or you do patella reflexes, those would be considered somatic reflex. You also have visceral reflexes that are going to be found within your GI tract, right? You have like the baroreceptor reflex. You have in your GI, when food and chyme is passing through your GI tract, you're going to have local reflexes, like local stimulation of peristaltic contractions. There's going to be different complexity involved in different types of reflexes. Some are monosynaptic, some are polysynaptic. They have multiple synapses. Interneurons, for example, are going to be involved in that. And you have reflexes that are going to depend on the location. So you have spinal reflexes and you have cranial reflexes. Spinal reflexes take place in the spine. So like monosynaptic reflex would be an example of that. And then you have cranial reflexes that take place in the brain. So here's innate reflex. Again, you're born with this. So suckling reflex, grasping reflex, right? The suckling reflex, obviously for children who are breastfeeding, grasping, when you put your hand in a baby's hand, it's going to clench its fingers around your finger, or it's going to clench its hand around your finger. Moral reflex, this is a test that you do in pediatrics to make sure there's no issues with the kids. Oh, whoops. That's what I meant to do. There's no issues with the kid's neurological development. So this is a very short video, but this is the moral reflex right here.
So this is the moral reflex by having him relax unsuspecting and then give him a sudden stimulus, and there's a good moral. Quiet, good midline, and then just give the stimulus of dropping him back a few inches, and that's a good moral response. Okay.
So that is the moral reflex. So as they're feeling like they're falling backwards, their hands come out, right? They're like basically trying to like grab for safety. Right? So that's a moral reflex. You're born with that. And again, acquired reflex, that's something you learn, right? Martial arts, driving, right? Like this video is amazing. Like the guy's tire, I think the tire comes off, or he just runs over a tire and the dude just immediately avoids danger, right? So these are things that you can learn. Now, somatic reflex, again, that's going to be your body, right? Stretch reflexes fall under that category, like patella reflex, patella tendon reflex. Also, the corneal reflex is another example of that. Corneal reflex is one of those things that you also use when you're diagnosing like a brainstem lesion or you're diagnosing brain death. You literally take a little bit of cotton wool, you like extend it out so it's like a little thin strand. You gently touch the cornea and the person should blink right away. So that's the corneal reflex. So you induce like a little bit of like discomfort and pain and you blink in response. And then visceral reflexes. Again, this is something you find within your GI tract. You find it also in your cardiovascular system. Baroreceptor reflex. Do you guys know what that is? What's the baroreceptor reflex? Do you remember?
If I go like this, I can calm myself.
Yeah, absolutely. You have baroreceptors in two areas. You have one in aortic arch, and you have another one in your carotid. So if you put pressure on those regions, it's basically, well, first of all, naturally speaking, like when your blood pressure is too high, if you have hypertension, those baroreceptors get stimulated, and it's going to allow for parasympathetic stimulation of the heart to slow the heart down, to bring the blood pressure down. But you can also induce that on yourself. If you feel like your heart's racing or beating out of your chest, you can literally do a carotid massage. Massage your carotids for a little bit. Like, don't choke yourself out, like, cut off all the blood circulation in the brain. But if you put enough pressure there, your heart rate is actually going to start slowing down, right? So that's the carotid massage, which has to do with the baroreceptors in there. So those are examples of visceral reflexes. So here's a little compare and contrast chart discussing the difference between somatic versus visceral reflexes. So here's a video.
I'm now checking for the corneal reflex, testing cranial nerve 5. To perform this reflex, you will need a cotton applicator or a cotton ball. Take the cotton tip and pull it out to a wisp. You will approach the patient from the side and ask him to look straight ahead for me, please. Okay. And you will look for a blink response when you touch the wisp to the eye. And get straight ahead for me, please.
Now, if you didn't have that, you would probably have a brainstem lesion of some sort. Right? And again, that's one of those tests that you use to even just diagnose brain death. Why did I hit escape? Give me a second. All right.
I'm now checking for the corneal.
Okay, there we go. Now, with monosynaptic reflex, you get afferents coming in, connecting directly to an efferent. So in this case over here, you have a monosynaptic reflex where you are striking the patella tendon. You get the afferent coming in, it's synapses with the efferent going out, and then you see stimulation of the extensor muscle. So that's basically just a simple monosynaptic type reflex. A polysynaptic reflex is going to involve at least one interneuron. And so the interneuron is going to basically come into play to help regulate things, right? They can either be inhibitory or they can be excitatory, depending on what you're looking at. Now, here's a reflex arc. This is where it basically starts with a stimulus, a painful stimulus, for example. Maybe you like touch a nail or something sharp. So that afferent comes in. And then you have stimulation of the interneuron. Interneuron could either be inhibitory or excitatory, depending on the circumstance. And then you have efferents coming out to the muscle to allow a muscle to be stimulated to allow for a withdrawal reflex. So this is called a withdrawal type reflex.
Reflex action and reflex arm. Whenever we happen to come close to an object that is capable of harming us, we immediately withdraw the part of the body that is the most vulnerable. This is called reflex action. When a person touches a hot cup, the sensory receptors in the hand send a stimulus via the afferent pathway, which contains afferent neurons, to the spinal cord. The afferent neurons enter the dorsal nerve root of the spinal cord. The stimulus is passed onto the efferent neuron, which travels the efferent pathway to reach the effector organ, in this case, the muscles of the arm. As a result, the hand is quickly pulled back. The brain is not involved in the reflex actions, as it would take more time for the impulses to travel to and fro from the brain. The afferent neurons or receptors, taking the causal stimulus to the CNS, the spinal cord, the efferent neurons or effectors, the exciter neurons, and the action performed in response to the stimulus together form the reflex arm.
Cool. All right, now the different types of muscles and fibers you're going to find within skeletal muscle. So first of all, again, you have your alpha motor neuron unit. Those are going to be what? Voluntary, or are those going to be afferents? The voluntary efferent or afferent? Alpha motor neuron units, are those voluntary efferent or are those afferent sensory type fibers? Yeah, so those are efferent. So those are going to allow for muscle contraction. Those are going to innervate the extrafusal muscle fibers. Extrafusal muscle fibers are the ones that are associated with voluntary muscle contraction. Now, within the extrafusal, you have intrafusal muscle fibers, and those are going to be predominantly sensory. Right? So they're going to be involved in changes of tension, right? They're going to also send signals to gamma motor neurons, and gamma motor neurons are going to be associated more with an afferent type of sensation. You also have group 1A afferents and group 2 afferents as well. We'll talk about those in more detail in a little bit. But muscle spindles, this is where you have basically stretch receptors, right? And these are going to be involved in protection for the most part. You want to protect your skeletal muscle, so you want to make sure that you don't overly stretch your skeletal muscle. So a lot of these different neurons and fibers are going to come into play to basically serve as a protective type mechanism. So if you stretch the muscle spindle, you get group 1A afferents being affected. Group 2s are also going to respond to stretch along with group 1A afferents. If you increase the stretch, you're going to see action potentials being affected by this, right? So that's the whole entire purpose of intrafusals, right? They're going to be sensory and motor. So intrafusal, think about them as being kind of like the afferent sensory portion of the muscle. Extrafusal, again, that's going to be contraction. Those are going to be voluntary muscles. Whenever you contract your muscle, you're contracting your extrafusal muscles. Okay, moving on. Sorry about that. It's a lag in the computer whenever I try to hit next. Now, alpha and gamma are going to be found, they're going to be synapsing with the anterior horn, right? When you have sensory input coming in from the dorsal column, it's going to be sending signals to the motor neurons coming off of the ventral horn of the spinal cord. Gamma going to intrafusal, alpha going to extrafusal. So again, alpha is synapsing with extrafusal muscles. Gamma is going to be synapsing with intrafusal muscles. And again, the whole entire purpose for this is to prevent overstretching. If you overstretch the muscles, you can potentially cause some serious damage. Muscle tears, right? Strains. This thing is not working. Sorry. There we go. Now, here's an example of the way that reflexes might come into play in a real-life scenario. For instance, you have an empty mug, and you're holding it steady. All of a sudden, you fill it up with something that's a little bit heavier, and now you're going to have to accommodate to that additional weight. And so that's going to be sending signals to your afferents, right? So from your intrafusal nerve fibers, you're going to have, for example, 1A afferents communicating with interneurons, and then you're going to see excitation of your flexor muscles and inhibition of your extensor muscles. So you have basically contraction of flexors and relaxation of extensors. So basically you can stabilize and accommodate the new weight that you're being exposed to. So you get basically a negative feedback loop coming into play here. So here's a breakdown of what's going on here. So you have increased activity in the 1A afferents. Then you're going to see increased activity of alpha neurons, right? So you can allow for stabilization of that new heavier object. So you're going to get excitation of flexors. You're going to get relaxation of the antagonistic muscles, aka in this case, your extensor muscles, for example, your triceps in this case. And so you can accommodate new weight. And again, this is all involving negative feedback systems. So you have new increased load that's going to stimulate the spindle receptors in your intrafusals. That's going to now send signals to the alpha motor neurons to allow for contraction of the flexor muscles. So that's the whole aspect of that negative feedback loop, particularly negative feedback on the extensors. So here's gamma motor neuron activity. So these are going to work in tandem with alpha motor neurons, but these are, again, working with the intrafusals instead of the extrafusals. The big thing that's going on here is basically coactivation, right? You're basically trying to prevent excessive amount of stretch, right? You're trying to prevent overloading of your muscles. And so here's some experiments that they conducted, taking the extrafusal muscle versus the intrafusal muscle, stimulating them and seeing what kind of effects will take place when you stimulate the muscle fibers. So in this case, they're stimulating specifically the alpha motor neuron unit. And so it's going to be stimulating the extrafusal muscle. And then they record what kind of effect that has on the intrafusal muscles, right? So you see what kind of afferent signals are going to be coming from intrafusals. As you stimulate those alpha motor neurons, you're going to see the intrafusals are going to undergo contraction as well, right? Now, in this case, they're stimulating both the alpha and the gamma motor neurons. And when you stimulate the gamma motor neurons, which stimulate the intrafusals, you're going to see more stimulation of your 1A afferents. Remember, your 1A afferents are the ones that are going to be responding to stretch, right? They're going to be responding to excessive amounts of stretch. And in both cases, you're going to be seeing contraction taking place. But you're going to see if the gammas are also stimulated, you're going to see more of a reaction from the gamma motor neurons. So long story short, alpha motor neurons, extrafusal, gamma motor neurons, intrafusal. The 1A afferents are the ones that are going to signal whether or not you're getting too much stretching or not. So it can basically help to protect the muscle fibers from overstretch. Another structure that's going to be really important for protection of overstretch is going to be the Golgi tendon organ. The Golgi tendon organ is going to be found at the border of the skeletal muscle as well as the actual tendon itself. And this is basically going to serve protection from overstretch by turning off the muscle. So this is something that would come into play like if you're picking up an object that's way too heavy. All of a sudden, you're just going to see immediate relaxation of those muscles. So you drop the object. So it really prevents excessive force and excessive stretch. So in this case, you're going to see total muscle relaxation, and you're going to see more of an antagonistic muscle contraction in this case, right? So whereas a reaction to holding an object that's slightly heavier, where you have to have more force contraction of the flexor and relaxation of the extensor, when the Golgi tendon reflex is initiated, you're going to have total relaxation of the flexor, and you're going to have more stimulation of the extensor, so you literally drop the object. And you do it as quickly as you possibly can. So you're trying to curl a 50-pound barbell. It's too heavy. And your arm relaxes. That's not that heavy though, right? 50 pounds? 50. 50. I'm not a super ripped dude, but I'm pretty sure I could curl 50 pounds. So the Golgi tendon organ, long story short, it protects the muscles. These are encapsulated. You're going to have afferent nerves being associated with these. They're going to be innervated by the 1B sensory axons. These are going to be GABAergic, right? So they're going to be inhibitory. They synapse with the alpha motor neurons, right? So they basically turn off those alpha motor neurons, right? As soon as there's too much force, too much stretch. And again, this is going to act on the extrafusal muscles, right, to allow for relaxation of the flexors and excitation of the extensors. So Golgi tendon is going to be 1B. Right? So intrafusal, 1A. Right? Golgi tendon is going to be 1B. 1B afferents. And the whole purpose is to decrease alpha motor neuron activity, preventing overstretch. So passive stretch or tension, you're going to see GTO activity is not going to be affected much, right? So the Golgi tendon organ is cool with that, right? You do a little bit of passive stretch, maybe a little bit of like extra force on there. It's not a big deal. But once you get a load that's too much, that's going to cause damage, that's when you see increased firing from the Golgi tendon organ. All right, so let's recap. What type of afferent fibers are you going to see associated with the intrafusal muscles? 1A. Good. Golgi tendon. What efferents are going to be innervating, or what motor neurons are going to be innervating the extrafusal muscles? Alpha. What about intrafusal? Gamma. Good. Awesome. Now, the flexion reflex pathway. You also have the extensor reflex pathway, or cross extension reflex. So flexion, cross extension reflex. Now, this has to do like you're walking along, and all of a sudden you step on something sharp, right? And you immediately have to retract your foot, right? Otherwise, you're going to cause even more damage. So the whole purpose of this cross extension reflex is basically to maintain your posture, right? If you all of a sudden step on a nail and you like withdraw your foot and you don't have this reflex, you're going to fall right over. Right? So this basically prevents an individual from falling over. So you have a nociceptive stimulation. You're going to activate the ipsilateral flexors. So you activate ipsilateral flexors so you can basically withdraw your foot, for example. And then you're going to have inhibition of the extensor muscles. And then on the opposite side, the contralateral limb, it's going to be the opposite, right? You're going to be stimulating the extensors and inhibiting the flexor, right? This whole entire pathway is basically to keep you standing up straight. So let's recap that. You step on something sharp, you're going to stimulate the flexor, to lift your foot up, right? In the case for your leg, your flexor is going to be your hamstrings, right? And your extensor is going to be your quadriceps. So you inhibit the quadriceps and you stimulate the hamstrings so you can withdraw your foot. And then on the other side, the contralateral side, the complete opposite is true. You're going to be stimulating contraction of the extensors and inhibiting the flexor muscle. So that keeps it simple for you guys, where you have literally the opposite taking place versus like the ipsilateral versus the contralateral appendage. To my knowledge, yes. To my knowledge, yes. I'd have to look into that for upper extremity. I don't think you get that with the upper extremity. Yeah, I know. I'm thinking about the same thing too. Like if you were like, if you're doing push-ups and then your hand hurt. Okay. Does cross extension reflex occur in upper extremity? So cross extension reflex. Where does the cross extension reflex occur? I'd have to look into that. An abnormal response is flexion of the upper limb. Simultaneous extension of the lower limb. That's really weird. It looks like the wiring got all crossed in this example. I'm not finding anything immediately. If you find something on that, let me know. As far as I'm concerned, that only happens really in the lower extremity because that's what basically keeps you upright. This one does happen in the upper extremity, right? The withdrawal reflex, right? If you touch something hot, you want to immediately let go of it. Touch something hot, touch something sharp, right? Even before your brain processes what just happened, before the pain stimulus even reaches your brain, you're going to have an immediate reaction, right? Just to protect your tissues. So here's another breakdown of the crossed extensor reflex. I'm sorry, you were asking about the flexion versus extensor muscles. Yeah, so if you step on step on the nail, right? How do you withdraw? You lift your foot up by flexing your hamstring, that's your flexor muscle, and relaxing your extensor, right? That's how you bring your foot back up. And the opposite leg is going to be true, like your quadriceps are going to be stimulated, whereas your flexors are going to be inhibited. So spinal reflex, here's your stretch reflex, right? You get muscle contraction, right, due to, for example, a deep tendon stimulation. We're going to do that to each other pretty soon here. Then you have Golgi tendon reflex. Again, this is where you have relaxation of your flexor muscles. Like if you're curling something and it's too heavy, you get relaxation of your flexors, excitation of your extensors so you can drop the object so you don't cause any damage. Again, to reiterate, the whole purpose is to protect, and the cross extensor reflex is to also further stabilize you from falling down. So let's get into some of these different types of stretch reflexes. So the stretch reflex is going to basically help to regulate length of the muscle. The stimulus is increasing the length of the muscle. When you hit the patella tendon, you're going to be basically causing the quadriceps to lengthen out a little bit, so they get a little bit longer. So the moment you hit the patella, it lengthens those quadriceps. And so that's the original stimulus. Then you have the sensory receptors. Those are going to be your muscle spindles are going to be stimulated. And then you have your motor response. And you're going to see contraction of the muscle that got stretched, right? So in other words, it's trying to prevent further stretching of that muscle. And so with the patellar reflex, that's going to be the quadriceps. The quadriceps are going to get stimulated. This is going to be involving both extrafusal and intrafusal muscles.
Welcome to 2-Minute Neuroscience.
Sorry about that. Let's go ahead and start that from the beginning. The lights. And then we're going to start. I'm going to show you a bunch of videos first, and then we're going to do patella and other types of reflexes on each other. So that's how we're going to close out today's class. Shoot.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the knee-jerk reflex.
The knee-jerk reflex, also known as the patellar reflex, is a well-known example of a simple reflex arc that allows us to maintain posture and balance. Most of us have had our knee-jerk reflex tested at a doctor's visit, when the doctor taps the tendon just below your kneecap, which is the patellar tendon, with a small hammer. This causes your lower leg to automatically kick outward. If this doesn't happen, or if it happens excessively, it can be an indication of a disorder or of damage to the nervous system. The knee-jerk reflex is a simple reflex arc that occurs at the level of the spinal cord. In other words, the associated movement occurs without the involvement of the brain. The brain receives information about the movement after it has been initiated. When the patellar tendon of the quadriceps muscle is stretched, the stretch is detected by stretch receptors known as muscle spindles that are found in the quadriceps muscle. The muscle spindles stimulate sensory neurons that travel to the spinal cord, where they synapse with motor neurons that control the contraction of the quadriceps muscle. These motor neurons cause immediate contraction of the quadriceps muscle to produce movement of the leg. The knee-jerk reflex is considered a monosynaptic reflex because it involves direct connections between sensory neurons and motor neurons without any neurons in between. Although the reflex is often simplified in diagrams to show only one sensory and one motor neuron, in reality the reflex involves many neurons. Stretching the quadriceps muscle activates several hundred sensory neurons, each of which makes contact with around 50 motor neurons. Additionally, the sensory neurons traveling from the muscle spindles stimulate interneurons that inhibit the activity of motor neurons that supply opposing muscles like the hamstring muscle. The stimulation of these inhibitory interneurons causes the action of the quadriceps muscle to be unopposed.
Cool. Now, last night I was trying to, because I was planning on bringing in my hammer, right? So I brought my neurology hammer that I've talked about quite a few times in this class, which is a really cool hammer. So here's just like a basic reflex hammer. So this is also the one I used to use in med school. Literally just a rubber mallet. That's all it is. The neurology hammer is really cool because it has like a little sharp point. So if you want to do any sort of like, pain sensation, if you're trying to check for like neuropathy, you can even get another needle and do like that 2-point discrimination test. You take like the point of that and just do like a 2-point discrimination. See at which point the person can actually perceive it as being 2 points. And then the other thing that's really cool about this hammer is that it's got something for like fine touch, which is literally just a tiny little brush. And you can like do like a little tiny fine touch to see if the person feels it on their feet or their hands or whatever. So that's like a special neurology type hammer, but generally speaking, most docs just use this. You don't even have to use a hammer. You can literally use your finger and tap the patella tendon. I was talking to my colleague, Dr. Jackson, today. He was saying that his one of his preceptors would use like the ophthalmoscope. He would use the handle where you have the batteries in the ophthalmoscope. He would use the handle to tap on people's patellas. And so yesterday I was trying to make sure that I was still good at eliciting a patella reflex. So I was using my wife as my guinea pig. And I tapped, nothing. I tapped again, nothing. I tapped a little harder, nothing. And I was like, am I tapping in the right spot? And I was like doing it on myself. And I was able to elicit on myself. And I was like, what the heck is going on here? And she was chuckling because that happens to her all the time. Even like other doctors in the clinic are like, you don't have any reflexes. What's going on here? And so, yeah. So I forgot about, this is Gendrasic's maneuver. Now this, if somebody has like hyperreflexia, some people just have that. And it's not necessarily abnormal, right? But if they do have that, the Gendrasic's maneuver is where you clench your teeth and you lock your hands together and you pull it apart. And basically what you're doing is you're distracting your brain from sending those signals that might be otherwise inhibitory down to the area that you're trying to test. And so this can actually help to overcome that issue. Now, if a person still has hyperreflexia, and I'm going to try this on her today, if a person still has hyperreflexia, maybe there might be something else going on. I don't know. But so that's the Gendrasic's maneuver. So whenever you guys are testing this on each other and you're not eliciting any sort of reaction, try doing this maneuver and see if that helps. So clench your teeth and then hold your hands tight and try to pull your fingers apart. Now, here are other types of reflexes. I'm not going to test you guys on these reflexes, but it's cool to see what types of reflexes are out there that you can use to do a thorough neurological exam. So this one, jaw jerk reflex, is specifically looking at the trigeminal nerve, cranial nerve 5.
This is a patient of exaggerated jaw jerk. We can see when I'm striking on the finger, we can see the closure of the lower jaw. We can see it again. There is closure of lower jaw. This is exaggerated jaw jerk.
If you want to do any of these, tests on each other, feel free to do so, because the Patel test is not the only one. There's other ones out there too. Here's the biceps reflex. You're looking at C5, C6. That's cervical. That's the cervical root 5 and cervical root 6. How about that?
Okay, so we are going to perform bicep reflex. So this is the bicep muscle, and we have to strike here at bicep tendon. Fine. How to do that? To prevent the injury of tendon, we have to hold the elbow like this and place thumb on the tendon, right? So we have to now strike the narrow end of hammer on the thumb. Let's see. Can you see the muscle movement and the elbow contraction? So bicep contraction will lead to elbow contraction, elbow flexion, right? Let's say again.
Cool. Brachioradialis reflex. You're looking at C6.
The patient sits on the treatment table with the feet flat on the ground. The examiner grasps then the patient's forearm with one hand and applies a brisk tap with the reflex hammer on the muscle tendon.
So it's brachioradialis. Brachioradialis goes from your brachium, which is your humerus, right, your proximal arm, radialis to your radius. So you just hit the brachioradialis and you should see that flexion take place. Extensor digitorum reflex. Some of these are really hard to find. So for this guy, he's like practicing on himself, drawing out the areas that he should be hitting. He's just whacking his arm. Some of them are really hard to elicit. So some of these are really tough to get.
You have to get them in like 1 or 2 of them.
I mean, otherwise you're just basically beating your patient.
The patient sits on the treatment table with their feet flat on the ground. The examiner grasps then the patient's arm with one hand and applies a brisk tap with the reflex hammer on the triceps tendon.
So triceps reflex. So you're looking at C6 and C7 there. Now here's your patella reflex.
The patella reflex is a monosynaptic spinal reflex. To observe this stretch reflex, first locate the patellar ligament. You can feel this ligament come under tension if the leg is slightly extended. Now make sure the leg is relaxed. Tap the patellar ligament and observe the knee extension that results.
I was freaking out yesterday. I'm like, I'm not getting any reflex from you to my wife. It's so funny. And now here's the last one, ankle jerk reflex. This one's kind of cool. We're not going to be doing this one to each other. Unless you have sandals or something, you don't have to take your shoes off. There's other ways you can do that as well. You can do a thing where you like basically rapidly move the distal portion of their foot up, and then you should get like a kind of a reaction to that, right? So that would be a different way to do the ankle jerk reflex. So with that being said, we got 15 minutes, so let's go ahead and do reflexes on each other. You can literally go through all these if you want. So partner up with somebody. I'll leave these out here so you guys can choose your poison, choose your hammer. It's best. It is best. You can sit on the table. Yeah, you sit on the table.
This is Schnauzer.
Yeah.
I used to do this for fun.
Do you want me to be your partner?
Yes.
All right. Where do you want to sit? You can sit right here if you like. Actually. All right. So let's go ahead and just relax. There we go. You did it. Now do it to me.
Okay.
All right.
Where do I go here?
You can feel for it. It's like right there. So if you feel the patella, it's right below there. Yeah. Do it again. Here, let me try this. Okay, do it again.
Yay! Good job. I like
There we go. That was awesome. That was a good one. Have you tried the jaw jerk reflex? Try doing that jaw jerk reflex. So you like put your finger, and you guys can use if you're grossed out at all, you can go ahead and do like the spray over there. But like you have the person relax their mouth, and then you just kind of hit your finger.
Can I like have like her put her finger on her mouth?
Yeah, you can do that too.
How hard am I supposed to hit it? Dude, her lips were just kind of like moving, I think, because I was just like hitting her face.
That's funny. Why don't you use some of this hand sanitizer and then use your finger? That might help. That might help a little bit. Let's try some of these other reflexes. You want to do? Want to try to do the biceps reflex? So try to do that on me. So I'll sit down. And so you gotta have my arm relaxed. So you gotta you gotta find the biceps tendon, which is right there. You might want to wrap your thumb around. So yeah, like that. And so go ahead and just whack it.
Oh, your touch land?
I felt something. I definitely felt something. Yeah. It just hurts your thumb. Yeah. Extensor digitorum reflex. Like literally, you're just like tapping.
Yeah, that was.
Yeah, you can literally just tap any of those.
I mean, I think it worked though.
Harder.
You had a reaction.
Oh, there you go. That was great. Triceps reflex. You have to have my arm like relaxed. So you have to like hold my arm up and then. There we go. That was it. Yeah, that was good.
Cool.
Ankle jerk reflex. I'm wearing boots.
Bicep. I'm not touching anybody's feet.
Yeah, no, don't touch anybody's feet. Kind of gross.
Sure.
Did you guys do these yet?
No.
All right, let's do it. All right. So you can start from you can start if you want to use sanitizer and do the jaw jerk reflex. You just have to put your finger, like relax your jaw, and then put your finger here, and then tap your finger, and you should see like the jaw close. So the jaw should like that. So, huh?
Where do I hit it for the bicep?
For the bicep, not like that. So for the bicep reflex,
This is tricep.
yeah. So you would,
Okay.
hold your arm up like this, and just whack right there. Yeah, that was it.
Okay.
Yep, that was it.
Wow.
Yeah.
Which one are you gonna do? Oh, whichever. You want to start with bicep one?
Yeah. So I just put my finger right.
Yep.
What about for the biceps?
Yeah. So she has to sit down for the bicep reflex. You gotta feel the bicep tendon.
Do like a little bit of that.
So.
And then triceps.
So maybe use this arm. Use this arm.
Nice muscles.
So you relax. So here's your bicep tendons like right about there. So you just like whack. You'd whack. I don't know if I'm doing it right.
Triceps. You have to hold that.
I'm just whacking my finger.
like you're pushing it so hard already, so there's already pressure.
Here, turn your arm around. These ones were cool. The extensor, relax your hand.
Those are cool.
Yeah, see?
Oh my gosh.
Yeah, super cool. Yeah, though.
That's cool. Like right here. Okay. Here.
Ah, that's a good reflex.
Oh, you kind of did it.
Those are good. Those are good. You didn't even have to do the clenching your jaw or anything. Yeah, that was good. That was really good.
Okay.
Want to do the ankle one?
You should, do the ankle one.
I had a hole in my sock.
So you're gonna have to kind of like get on the. You're gonna have to kind of get on the chair.
And those are destroyed too.
You can do it if you want.
Clearly, I need to buy new socks. So
You got to kind of relax, and then when you hit the tendon, the calcaneal tendon, you're gonna see his foot move. There you go. Yep, that's it. That's it. Very cool.
Looks like the one where like, because I feel like whenever I like go to like the nail salon, if they like squeeze like my like wrist, like my fingers like clench in. Is that a reflex?
I mean,
Like,
it's
they'll be,
probably
like,
they're probably
massaging,
just
like, my wrist
they're
and then,
probably
like-
just stimulating the median nerve,
Yeah.
and the median nerve is going to be innervating a lot of the flexors in your hand.
I know that when people like grab your iron when they're like curling, they actually grab the barrel instead of they grab the barrel, like when they're burning their hand.
No,
What?
I'm not familiar with this. Is this
Perfect.
for
No,
doing
it just,
hair?
Like, happens. I know it happens. Like
Oh.
people like instead of like moving away, they accidentally like they grab the barrel as
Oh.
like a initial.
Oh, like they have the wrong reflex
Yeah.
and they end up burning themselves more.
So they burn themselves more when they do that? Oh, okay.
I heard
try
that
that
was
with our
a thing
one?
that happens
yeah.
if you. I don't know.
Yeah. That's not good.
That only happened to me once when I was like getting like a piano at 11, it like started falling and like I only had like one oven mitt on it and it started like slipping out. And I literally was like, that's like,
You're like, wait, no, I can't do that.
So
Biceps.
So,
we got 5 minutes left for class. You guys want to talk about anything, or do you want to get out of here?
what's the craziest thing you encountered?
In clinic?
Yes, in clinic.
Oh gosh.
Like, do you have like a top 5? Like it doesn't have
Yeah,
to be
one of the
crazy.
craziest stories one of the craziest things I experienced was my first day in psychiatry. This is my first day. There's this guy who was probably like 300 pounds. He was probably about this tall. Massive dude. Massive dude. And so this guy had like really, really severe bipolar. And he would go into like psychotic episodes. Now, the first day that I was at the psych ward, they have this thing that they page over the hospital speakers. You know, that when somebody's coding, they do like a code blue type of thing. For this hospital, they had Dr. Strong, which means a very combative patient. And then all of a sudden, like my whole team, like they're all running through the hallways and just like chaos. And all of a sudden, we get to the hallway where this patient literally busted through 2 reinforced doors from the psych ward and was running amok through the hospital. And there was like 4 equally large security guards like holding him down while they were injecting him with the sedative cocktail. They usually use, it's haloperidol, Benadryl, which is diphenhydramine, plus Ativan. So it's like a 3-drug cocktail to wipe him out. And they injected him with one, and usually it happens really fast. They'll like get sedated. And then they're like, he's not sedating. So they had to inject him again. And the dude was like, they had to strap him down to with restraints on his bed. And he was just like yelling out loud. He's like, I'm King Tut. And he was going crazy. Yeah, it was weird. He was like yelling that he was King Tut and that he was going to like kill them all. And so that was my first day experience at the psych ward. I was like, dude, this is awesome. And I loved it. And so I was there for a month and a half. The guy was readmitted to the hospital. So this guy was only 19 years old. And he was massive and like violently like psychotic. And he was hospitalized because he was trying to strangle his father to death. And during his inpatient stay, he was at one of like the high security acute care wards. He again like went crazy. He ran through the hallway, and he was tall enough to reach the ceilings. He went through the hallway, ripping the entire ceiling, and all the AC units were like dangling down from this. It looked like a hurricane came through there. Absolutely insane. Like I took a photograph of the hallway after like he destroyed everything, because people were like, dude, you need to go see this. The nurses all had to hide behind like the little like reinforced like area and stuff. It was absolutely insane. So that's like one of the craziest guys I've ever seen in my entire life. Yeah, totally wild. Like extremely violent. So that was like one of the craziest things in psych. Now, in terms of other illnesses, I mean, I've seen so much crazy stuff that it's hard to like narrow it down. But that was by far one of the ones that stuck.
So when you talk about certain things, those are all real. Because sometimes I'm like, you're just like.
The stories that I share with you guys are especially from firsthand account. That's all real stuff.
Okay.
Yeah. Yeah. That was another really interesting case. This one was really sad. This was a kid that was in our ward, and he actually was like in the newspapers. You know, his sister died, and his parents were serving a life sentence, and he was in our hospital, and he was only like 6 years old or something, but he had some massive issues at 6 years of age, and it's because he was tied to a radiator for over a year and being starved and like physically abused. Like literally, his sister was killed by the parents.
Oh, that's
basically.
why they're.
Yeah.
Okay.
And then the other story that's really crazy was, did I tell you guys about the guy that cut his dad's head off?
No.
Maybe in Patho. So this guy, super nice guy. Like he came into the hospital, right? He tried to convince.
You say super nice.
Yeah, super nice guy. That's one of the craziest stories to me. Like the guy was just such a sweetheart. But he was an axe murderer. Like cut his dad's head off. Like that's wild.
Didn't you say his dad was doing stuff to
Very
him?
abusive.
Yeah.
His sister actually left. The sister left the household. She became a very successful lady on Wall Street. So she was working in the financial district. And he was institutionalized for 20 years after cutting his dad's head off. And tried to get trained while he became a dental hygienist. Nobody wanted to hire him because of his history. And then he tried committing suicide. And that's when we saw him. So stuff like that you will see in a psych ward like all the time. There was one guy, this is the funniest one. One guy, he was always talking about, man, he's like, I've been trying to talk to Britney Spears for so long. You know, I really miss her. Like they were like dating. And we're like, oh, come on, dude. Total BS. This is like in New York. It's like Britney Spears doesn't even live here. He's actually from California. Turns out when Britney Spears went crazy and was institutionalized in the hospital, he was at the same institution. So they were like actually hanging out together. And so that was like his girlfriend and stuff. But the story kind of checked out. At least they knew each other from the hospital. So stuff like that is like really cool. Yeah. That's why I liked psych so much, because it was never a dull moment. It was always really fascinating. Neuro, also never a dull moment, but also extremely depressing. Yeah, very depressing. It takes a special kind of person to be a neurologist. So this is where we're going to start off next week. We're going to finish up with lower and upper motor neuron. We're going to talk about ALS, and then we're going to begin other motor type topics as well. I can't remember off the top of my head. Still working on it. And then we're probably going to close out. I think the last lecture is going to be on a little bit of cognitive neuroscience. And we're just going to talk about like learning and memory. And I want to talk about Alzheimer's. So we're going to go into Parkinson's, Lewy body dementia, and Alzheimer's. And that's kind of how we're going to close out the semester. Sound good? Rock and roll, guys. Well, have a wonderful afternoon.
You as well.
Thank you. Oh, yeah. And have a wonderful weekend.
Yeah.
Yeah.